This conference will now be
So
recorded.
welcome to class. So today, I'll be doing this class for fertility guideline because this has been updated in the March 2026, and I have the discussion of guideline followed by some questions for part two, and there is one part three task also. Now, so infertility, it affects 1 in 7 heterosexual couples in UK, and these are the causes for infertility. Unexplained infertility will be like 25%. Ovulatory disorders causing infertility 25%. Tubal damage is 20%. Factors in male infertility is for 30%. And uterine causes like 10%. And the both male and female, the 40% the disorders would be there in both of them. So this is the percentages that defines the cause of infertility. Though these percentages are not given in the new guideline, but there are so many questions come from these percentages. Because of that, I have put it here. Now, psychological impact of the fertility, like stresses, likes to reduce libido and the frequency of intercourse, and because of that, the counseling before, after, and the during treatment is done, and there should be an independent counselor. Now, why it is important? This would be necessary to know by the part three people, because whenever we are doing in fertility stations, and and some cause is there, we have to arrange an independent counseling for the fertility when the investigations and the treatment is going on. Independent counselor will be the person who is not involved in the fertility treatment, okay, and the support groups. So all this part would be necessary for the part three people. Why you have to put independent counselor in your tasks. Now, 80% chances of conception, 80% will conceive in 1 year if the woman is under 40, not using contraception, regular intercourse, and like second by the second year, cumulative pregnancy rate will be 90%. So 80% in 1 year and 90% in 2 years. These percentages are important for the part two people. Chances of conception, again this guidelines, this all the tables have been added new in the guideline, and these percentages have been changed. It will be necessary roughly idea for part 3 people, and part 2 people should know it definitely, because direct question can come from here. So IUI percentages of success is 47 to 57 if the 6 cycles of IUI is done. If the 12 cycles of IUI is done, then the cumulative pregnancy rate is like 72 to 81%. So these numbers are important for both part 2 definite numbers and part 3 people rough numbers, because whenever you are giving IUI as an option, you have to explain risk and benefit to your role player. That time, sometime the percentages are also asked by the role player. The chances of conception, the fertility, to and the male and female both fertility decreases with the age. This graph was given in the guideline, so I put it here. You can see the fertility declines. That is nothing new, we already know this. Apart from this part is important for part 3 people. Many of the RCOG recommends that the vaginal sexual course frequency will be two every second 2 to 3 days. That optimize chances of pregnancy. Many of the students do this mistake. They will ask, "Do you know the fertile window or whatever?" So this fertile window concept, it is not given by NHS or RCOG. Because this will take away your one of the marks, because according to RCOG, asking having intercourse during fertile window increases the stress. So please, for your role player, do ask frequency of intercourse. Coital frequency is very important part for the fertility stations. But yeah, if the insemination is being done, it has to be done during the ovulation. Okay. So apart from this lifestyle modification, now, there had been some change from the previous guideline. They're necessary to know by the board part 2 and part 3 people. Now, in this guideline, whenever they're speaking about female, They are saying female women, trans women, binary, non-binary people with male, female reproductive function. That means there is including female includes everyone with a female reproductive function, and male trans men, non-binary male. So male includes all with the male reproductive function. So this is the change in this guideline. Every part of the guideline they're using the same terminology, but I have put this in a couple of slides only. That is understandable. If I'm saying female, that means all of these people. If I'm saying male, that includes all of these people. Now coming to alcohol, drinking one or two, now this is for the females, okay? So drinking one, no more than 1 or 2 units of alcohol once or twice a week. Then intoxication or like to be avoided, because that causes fetal alcohol syndrome. Safest approach is to avoid alcohol. This counseling is necessary for your role players. And also for part 2 you will get the direct question. So drinking not more than 1 to 2 units once or twice a week. Ideal approach is to avoid intoxication. Should not be done. For the men, now the chief medical officer advice is 14 units per day, per week, that spread several weeks, up to 2 units per day, unlikely to affect semen quality. So excessive intake should not be done. So this part is important, because you may get question in part 2 and part 3. People, they will ask directly, the role player may ask you, is there is any safe limit for the alcohol. Then you have to say like up to 1 to 2 units per day, and not more than 14 units in 1 week. Ideal approach not to take. Okay, so this part has been changed in the guideline, these thresholds. Now smoking for the female, they should, it reduces fertility, and also referral to smoking cessation program. Passive smoking also, like, affect the chance of getting conceived. And for the male person, there is association of a smoking in the reduced semen, uh, the quality is there, but consistent evidence is not there. So this part you have to explain to the person, male infertility, that there would be reduce in the semen quality, but consistent evidence on the fertility issues is not available. Okay. So apart from this, for caffeine, there is no there is no consistent evidence that the caffeinated drinks are related to the fertility problems. So we don't have evidence if the role player asks that. Then obesity, yes, more for the females, those who are more than 30 BMI, not ovulating, they should be given guidance about the weight loss. They can participate in the group exercise programs and the dietary advices for the weight loss. For male, BMI over 40, BMI over 30 also likely to have reduced fertility. So previous guideline they were saying obesity for the female only, but now they are saying obesity for the male also. Okay. Apart from this, this part also added that if the BMI is less than, this number has been changed. Previously it was 19. Now they have said that if BMI is less than 18.5, then in that situation the person should be advised to increase weight. Okay, because we already know if the low weight is there, then they would have hypothalamic suppression. Tight underwears, though they increases the scrotal temperature and reduce semen quality, but evidence is not there that the loose fitting underwear improves the fertility. Important to know by part the 3 people, the role player may ask this question. Some occupation may affect fertility. For example, proper advice from the work occupational health advisor or occupational health team has to be taken. Now, other modification, like if the patient is on GLP-1 agonist, these are the weight loss medication, on testosterone therapy, or finasteride, or NSAIDs, or recreational drugs, proper history has to be taken, and advice these medication will cause on the fertility and pregnancy has to be given. and there is no complementary therapy that sorts out the fertility issues. Now, about the folic acid, uh, what they say, folic acid uh, should to be taken ideally 3 months before. Previous guideline it was mentioned 1 month, but ideally it is 3 months before, and continue till first 12 weeks of pregnancy. And like there is a healthy start program where daily dose of folic acid, vitamin C, and vitamin D are given. Now, where high dose of folic acid to be taken, so these are the like these are the situation where a high dose of folic acid 5 milligram per day would be necessary. So if if the female member or their partner, or they have family history of NTD or the neural tube defect. Now, if previous baby is affected by neural tube defect, if they have type 1 and type 2 diabetes, if hematological conditions like sickle cell anemia and thalassemia, if the patient is taking the medication where folic acid absorption is affected, for example, anti-epileptic medications, and the antiretroviral therapy for HIV. Okay, so these are the indications for high dose of folic acid. Fertility assessment. Now, when the fertility assessment has to be done, or what could be the definition of infertility? If the female has not conceived after 1 year of completed intercourse, and when there is no suspected or clinical causes there, or they have not conceived after 6 cycles of insemination. So these are the definition. If the patient is coming after 1 year of unprotected sex or 6 cycle of IUI and no conception, then we need to consider investigating them. These are the marker where fertility assessment has to be done. But there have been, like special, waiting is not required, and immediate fertility assessment has to be done. Why? If the female patient is more than 36 or older, because we know that after 37 fertility declines and the patient is already coming to, she's already 36, in that situation waiting for 1 year will not be required. Or if they have any known cause of infertility apart from this, uh, where they are in some kind of treatment, their fertility will be impacted. So this will be the conditions where like immediate fertility assessment or specialized consultation will be done. Now, fertility assessment, this part, okay. If the according to the time frames, if 1 year of unprotected intercourse is there, if in explained infertility, they've already crossed the time limit. If 12 cycles of artificial insemination and has been already done, 12 cycles, in that situation, okay, so sorry, if the so let me tell this again. So fertility, this is the fertility assessment definition. If the patient comes after 1 year of unprotected intercourse, we need to investigate. And if the patient has not conceived after 6 cycle of insemination, we have to investigate the patient. These are the special circumstances where at presentation only the specialist consultation will be done. When the patient is more than 36 years of age, known cause of infertility, or the patient is on under any kind of treatment, such as where fertility will be impacted, such as treatment for cancer. But like when they are in this time frames, and if they have miscarriage or if they have ectopic pregnancy, then the time frame for the fertility assessment will not change, it will be same only. So this part was not there previously, previous guideline. They have added new in this guideline only. Okay, if any of the and in the time frame like 1 year of unprotected intercourse, anytime they have miscarriage, so that their time of infertility assessment will not start after miscarriage, it would be continue only. Okay, and if the period of expectant management for unexplained infertility, like the patient is for unexplained infertility, they have miscarriage, so it is not that after miscarriage they have to start the time frame of unexplained infertility. It will be included in that. Okay. So a 12 cycle of artificial insemination, but if the patient is already having some miscarriage and ectopic, so there will be no change in the time frame. So this part was new in this guideline. Now investigation, any question till now? Okay. Now, investigation for male infertility. There had been a couple of changes in this topic. So, first of all, this semen analysis. This semen reference ranges you have to remember only, because the part two people also get question. Part three people, they will give you the semen analysis in your male infertility or female infertility task. Unless you know the normal, you cannot get what is going wrong. So semen volume, previously it was 1.5 ml or more, but now it is 1.4 ml. pH is same. Semen sperm concentration is, like previously it was 15, now it is 16 million per ml or more. Total sperm count is same, 39 per ejaculate. Total motility previously was like previously it was I think it was it was 40 or something, I don't remember exactly, but now the motility is 42%. Previously it was not 42. Progressive motility is 30, and the vitality is 54, and sperm morphology, like normal form should be 4% and more. So what are the so this is the new parameters whatever from the WHO, and you should be aware of that. So major changes, this 16 million and mortality 42%. Okay. Semen volume doesn't make any sense, but yeah, previously it was 1.5. Now, if the semen analysis is abnormal, then we need to repeat the test within 3 month time. That is same, we know. But if we see the patient has got azoospermia or severe oligospermia, that time repeat test to be done as soon as possible. In this situation, we will not wait for 3 months. Okay. Sperm antibody test should not be done, and test for a DNA sperm integrity or fragmentation should not be done. These are not recommended tests. Now, if this is newly added in the guideline, if two or more abnormal semen analysis, like 2 times semen analysis is showing some changes, then next step would be to offer physical examination of testes and scrotum, and doing investigation for testosterone and gonadotropin levels. Okay, so this part has been added new. Part 2 people will get some SBA from here. So that two semens are normal. What is the next step? To examine the patient, testis and scrotum, and do the investigation, hormonal investigation. That will be testosterone and gonadotropins. Now, Y chromosome microdeletion testing. So this also the guideline have been added. These things, all both of the things are new. So Y chromosome microdeletion testing, what are the indication? If there is idiopathic azoospermia or sperm concentration is less than 1 million per ml. So these are the two indications for Y chromosome microdeletion testing. Okay, so this part is new in this guideline that you should be aware of. Part 2 people will get to know in their question. Part 3 people may get some new task in the November exam. Now again, few updates. uh, Test for cystic fibrosis transmembrane conductance regulator genetic mutation, like they want to checks for the cystic fibrosis if there is obstructed azoospermia or vessel abnormality or both during examination. Like because we know that in like cystic fibrosis there is a congenital absence of vas is there. So if azoospermia obstructive, that means formation of spermatozoa is there, but obstruction is there or vessel abnormality, then test for cystic fibrosis transmembrane conductance regulatory genetic mutations are done. This is again new in the guideline. Another new thing that has been added is a karyotype testing. And what are the indication for that? Idiopathic azoospermia, persistent sperm concentration of less than 5 million per ml. So, and before this, like genetic counseling if any genetic defect has been identified. So you guys should remember the where what to do if two semen samples are abnormal. This is examination, testosterone and gonadotropin test. When to do chromosome microdeletion testing if idiopathic azoospermia or count is less than 1 million. When to do cystic fibrosis gene testing if obstetric azoospermia and Vossel abnormality. When to do karyotype if it is less than 5 million. Okay, 5 million, remember that, and if idiopathic azoospermia is there. So these are the updates in the investigations for the male infertility. Now, coming to the female infertility investigation, ovarian reserve testing. So, maternal age is a predictor for overall, chance to become pregnant that we already know. Another is AMH and AFC. These are the predictor for ovarian reserve. People previous guideline the number was mentioned and the reference ranges were given, but in this guideline they have not given any reference for AMH or AFC, so I have not put that. Apart from this, in previous guideline, even the FSH value was given. In this new guideline, they are saying that FSH should not be used as a predictor of ovarian response or outcome for assisted conception. So please be careful. Part 2 people may get a question from this line, and part 3 people also you have to say that when you are speaking about the ovarian reserve you will speak about the AMH and AFC only. So this is again small change in the guideline. Now if the patient is periods are regular, they assume she is ovulating. Otherwise, how to do the confirmation for ovulation? On 21 day of cycle or in 28 day cycle they will do the serum progesterone test. So if the serum progesterone test is like more than 30, usually we say the patient is ovulating. So day 21 progesterone more than 30 nanomole per liter, patient is ovulating. So this number is important because many of the student in the exam they don't remember this number, so they are not able to find whether the patient is ovulating or not. Okay, this is when the periods are regular 28 days cycle. But if the patient comes to you with irregular menstrual cycle, in that situation, they will measure serum progesterone like day 21 and they will repeat after every 7 day till the menstrual cycle starts. So like 21 day, 28 day, like this way they will repeat it unless to find out whether the patient is ovulating or not. Now, if the patient comes to you where there is a completely irregular cycle, then they do test to check for FSH and LH. Okay. Now, this is important because you will get in your questions this knowledge from there. Now, prolactin should not be measured as a routine. It is only done if the patient has ovulatory disorder, galactoria, or pituitary tumors. So, it is not the routine test. Thyroid function tests are also not routine. If any symptoms or thyroid disease is there, then only thyroid function test should be done. Mostly, the students will do all these investigation as a routine, as we do in our practice. But people for this exam, we have to follow NICE, and prolactin and thyroid tests are only done when they are indicated. Now, tubal testing. So, the history is taken. If the patient has no comorbidity, then HSG is done. So, like hycosi should also be considered as alternative to HSG. But if the patient has got any comorbidity such as PID, previous ectopic, or you can say previous abdominal surgery or endometriosis, in that situation, then the option for to find out the tubal testing will be lap and dye. Okay. Now, test for viral testing. So whenever the IVF is offered, you know, the this is the baseline investigation that are offered to every person. That will be viral markers, HIV, hepatitis B, and hepatitis C. Now, if the donor, if for donor insemination found to be tested for these tests, then they should be given specialist advice and counseling for the clinical management. Now, like with regards to HIV, it is same. It was same in the previous guideline. The patient can have, like, if the female is negative and the male is positive, then what are the condition when they can get pregnant by intercourse, and female will have like negligible risk of transmission if the male is compliant with the antiretroviral therapy, if the copies are less than 50 for more than 6 months, if no other infection is present, if it is limited intercourse during ovulation. So this part is same from the previous guideline. If the copies are more than 50, then sperm washing. If the person is not compliant, viral load is 50 copies or more, then sperm washing is offered. And if there is unacceptable risk of transmission, then also the sperm washing is offered. But it is not like that the woman should get pre-exposure prophylaxis. This is not recommended. So these are the conditions where the intercourse can be considered for like a conception. And these are the conditions like copies are more, patient is there is an unacceptable risk of HIV. In that situation, the sperm washing to be done. Now for hepatitis B, if the male person has hepatitis, female should be offered vaccination prior to starting fertility treatment. If the man has hepatitis C, then, like, though hepatitis C transfer during sex is very low, but the patient to be referred to the hepatologist, and they should be get complete treatment to eradicate hepatitis C, because for hepatitis C that antiviral and immunoglobulins are given. These cannot be given during pregnancy, so male partner has to be treated prior they go to the fertility treatment. Now this is again for the female what they are writing. So they should be testing for the rubella status if it is uncertain. So if the patient is female patient, she's susceptible to rubella, vaccination to be offered. As rubella is a live vaccination, so patient is advised not to get pregnant 1 month after vaccination. Okay, cervical screening has to be seen as per the cervical screening program. Chlamydia testing before any intrauterine procedure. They do chlamydia testing, and if the test is positive, then the treatment and contact tracing. Otherwise, prophylactic antibiotic should be done before uterine instrumentation if the screening has not been carried out. Now, this knowledge will be necessary for part 3 people and part 2 both. In part 3 people, when you are doing preoperative ward round task, sometimes you will find a patient for diagnostic lab and die. Now, that patient, you have to say, we are going to do swabs, or we are going to arrange prophylactic antibiotic. So that carries a marks in that task, and the reason you get from here, from the NICE guidelines. These are the old things only. This is a new part that has been added in the guideline. There should be celiac disease testing if the patient has got unexplained infertility. Basically, the guideline has given in this fertility guideline, they have given links to various other websites. So this is the link they have given, and in the celiac disease website, so there they pointed out this. So if the patient has unexplained infertility, then the testing for celiac disease to be done. This was added new in this guideline, it was not given before. Any question till now? Okay, now coming to the treatment for the male infertility, what the NICE guidelines suggest. If the patient has got hypogonadotropic hypogonadism, then gonadotropin drugs are offered. Okay. If the patient has impaired, so this part was not given in previous guidelines. So if the hypogonadotropic hypogonadism, that means hypothalamus is at cause, so gonadotropins are given. If the patient has impaired semen parameters, no hypogonadotropic hypogonadism, consider, so the here it is offer, here it is consider gonadotropin anti-testosterone therapy. So this part has been added new in this guideline, though we already in our clinical practice, when the patient comes to us with like impaired semen, we usually write clomiphene citrate, that is anti-estrogen only. But the NICE guideline had, so we are doing this practice clinically for a long time, but the NICE guideline has put this treatment now only. So impaired semen, answer you will give, consider gonadotropin or anti-testosterone therapy. Apart from this, people, it is important no androgen or bromocriptine is given, no supplement antioxidant is given, no steroid is given in case of sperm antibodies, and no antibiotic is given if the patient has got leukocyte. This part is important basically for part 2 people, because your role player will ask, can I take this, can I take this to improve that? So you have to say no, that we really don't have an evidence to give this as a treatment option. Because of that, I have put this all no in the red. Now surgical treatment. So obstructive azoospermia, surgical correction and sperm retrieval, and it to be done. But the female, before we do surgical correction, like the male factor we are able to find out, but before we offer any kind of surgical correction or sperm retrieval, it is important we need to see whether the female is fine or any infertility factor is there. Obstructive interval, if we know, and the risk and benefit of the surgical intervention to be explained to the patient, and the patient choice also. So for obstructive azoospermia, the option is correction, surgical correction, sperm retrieval. So before that, female fertility has to be assessed. In cases of non-obstructive azoospermia, like there is no problem. So the options will be surgical sperm retrieval, consider microscopic testicular sperm extraction, that is microtessi. Okay. So with a microscopic needle, they take out the tissue and they look for the sperms. So these are the microtessi. So this part has been added again new in this guideline. So obstructive azoospermia, a surgical correction with all fact checks, female fertility prior. Non-obstructive azoospermia, there will be surgical sperm retrieval and the process being microtessi. Now this also added new in this guideline. Previously, the guideline used to say for varicocele, no treatment required. But now, what the guideline says for varicocele, consider radiological and surgical treatment if the patient is trying and they have reduced semen parameter. So, this is new heading in the guideline. Now, ejaculatory failure, this is also new. They say that we need to find out the cause, and a least invasive method has to be offered in this condition. So these are updates from the guideline. Apart from this, what they say, if the patient has got Y chromosome microdeletion, don't offer surgical sperm retrieval. If the reduced semen is sperm integrity, then also surgical retrieval should not be done, because by retrieving semen, we can't do any help or treat management for to change the sperm DNA integrity or for the microdeletion. So no surgical choice is offered in these cases. So this is the surgical option. So, like this is the new updates with regards to male infertility in this guideline. Any question, people, till now? Okay, now coming to the female infertility. So, classification of ovulatory disorders that we already know. Group 1 will be hypothalamic uh, and hypogonadism. Group 2 will be HPO axis dysfunction, PCOS, and group 3 will be ovarian failure. Now, if the patient is having hypogonadotropic hypogonadism, what could be the treatment options? If the BMI is usually they are less BMI, if it is less than 18.5, the patient has to increase, they're advised to increase weight. And if they're too much of a excessive exercises, so they have to kind of moderate or decrease the exercises. So this is the the options for the patient who is having hypogonadotropic hypogonadism, lifestyle changes. Medical treatment can also be offered because these are hypothalamic causes. So injection can be given. These are the gonadotropin with the luteinizing hormone activity and gonadotropin releasing hormone. So gonadotropin and GnRH releasing hormone. These are the answer that can be offered. Now, second line is people is the PCOS. Now, PCOS, the previously RCOG guideline was there for PCOS, but that guideline has been archived by RCOG, and now the like the RCOG asked to follow ASHRAE European guideline. Apart from this, there is new PCOS guideline will be coming maybe in the 2026 December or maybe next year. So till that time we have to follow ASHRAE only. So this is the treatment plan from the ASHRAE guideline for polycystic ovarian syndrome. So now what the guideline says. So because um, the guideline has been archived, so it is ASHRAE. So first line for the PCOS will be the medical treatment. That will be letrozole with increasing dose as required, or clomiphene citrate plus metformin. Prefer to clomiphene again. Clomiphene, metformin, like these are low cost, low efficacy, no monitoring required. Or gonadotropin has a high cost, multiple pregnancy, high dose, and efficacy and monitoring is required. So basically, first line will be letrozole or clomiphene plus metformin or gonadotropins. So this is the first line. Now, second line treatment is gonadotropin with US monitoring and repeated cycle considering age, or LOD for the ovarian surgery. This will come in the second line. Third line will be IVF and repeated cycle, whatever the shared decision making. So this is the hierarchy that you have to follow for the PCOS. So let me repeat it again. First line is letrozole or clomiphene citrate plus metformin or gonadotropin. Second line will be gonadotropin with USG monitoring or LOD. Third will be IVF. Okay. So this is necessary for you because the PCOS will come in every exam. It is favorite topic. Is it clear, people? Hyperprolactinemia. That like if it is diagnosed, then cabergoline to be offered. So this is from the NICE guideline. Cabergoline doses are not given. Now in tubal conditions. So tubal surgery ideally to be done in the centers where expertise are available. If the proximal tubal condition, that is like a proximal block, cornual block, so catheterization by hysteroscopy or radiological guidance after discussing the risk and benefit. Okay, so this is the answer to cornual block or the proximal, tubal uh, obstruction. Apart from this, distal tubal disease is the hydrosalpinx that we know. Now, previously it was selfingectomy. But this guideline, they say laparoscopic selfingectomy or tubal occlusion for the hydrosalpinx before IVF. Another thing they have added, aspiration of hydrosalpinx at the time of oocyte retrieval if the surgery complications are high, and we are not, okay, we cannot offer that. Now this part is important for you guys. Part 2 people, you may get this question. They will write, give you a question that the hydrosalpinx surgery cannot be done because the patient has got comorbidities. What will be the treatment? So your answer will be like aspiration of hydrosalpinx close to at the same time when the like oocyte retrieval is done. For part 3 people also, you may get hydrosalpinx question. It usually comes only, so you have to give in this option also. Now option has to be changed as per the guideline. So this is the new update in this guideline only. Now uterine surgery offer hysteroscopy, adhesiolysis that restores menstruation, improves chances improves the chances for conception. Now endometriosis, what they say, that expectant management up to 2 years and or surgical treatment of endometriosis. Now, if the patient has not conceived in 2 years of expectant management or or surgical treatment or both, 2 years are passed in endometriosis with either kind of management, patient is not conceived. So previous guideline, we say directly IVF. In this guideline, the options are changed. Now they say 4 cycle of IUI with ovarian stimulating using gonadotropins before IVF treatment or directly IVF. So this part has been changed in the new guideline. So now they say 4 cycle of IUI with the ovarian stimulation can be considered before IVF. This is one option. And if your patient is not happy, then go for the IVF treatment. So this is change in this guideline. Now unstimulated uterine in intrauterine insemination. So before the patient is eligible for IVF, 12 cycles of intrauterine insemination should be done. Okay. So like indication for IUI, if the vaginal intercourse is not possible, or if the patient is using donor sperm treatment, then the male factor infertility is there. If the woman has not conceived after 6 IUI cycles, then 6 cycle more to be offered. So before IVF, the patient should have 12 cycles of IUI. This part was there in the previous guideline also. Now, unexplained infertility, again, there had been change here. Previously, we say IVF after 2 years, but now they have said that patient can consider 4 cycle of IUI with gonadotropin stimulation or directly IVF. So in like unexplained infertility, endometriosis after treatment. So these options are changed. First, consideration of IUI 4 cycle followed by IVF or directly IVF. Apart from this criteria for IVF, now IVF can be offered the patient who has not achieved their 42 birthday if there is diagnosed cause of infertility, unexplained infertility not conceived after 2 years, if there had been 12 cycles of artificial insemination. So, what is the full cycle? Full cycle will include 1 cycle of stimulation and transfer of embryo. So, the patient to be offered, you know, a 3 cycle of IUI with or without ICSI. If the woman reaches 40 during treatment, then the patient will complete the current cycle, but further cycle will not be offered. Okay, so now if the patient started treatment at 38 or for example 39 and she reaches 40 on the second cycle of IVF, then she will not be given third cycle. Okay, so this part you should know. This is added new in the guideline. If the patient under 40 has self-funded treatment, and that does it is that does not rule out their access to the NHS funded treatment, but they count all previous full cycles, funded or non-funded, in the total number of cycle offered by NHS. So what is the meaning of this line? That it is see, there would be the cycles, IVF cycles funded by NHS, and there are certain criteria for the funding is there. But so usually the three cycles are offered less than 40 years of age. Okay. Now, if we consider a scenario where a person went to the self-funded treatment, like private treatment, now if the patient wants, she can come back to NHS funded treatment. But any previous cycle, if she has gone, though it will be by her own money, it will be included in the total number of cycles. Is it clear, people? Is it clear? What does it mean?
Yes, ma'am.
Okay. So that means any cycle less than 40, if she has done privately, that would be included in the total number of cycles, basically. So now criteria for IVF: 40, 41 years, offer one full cycle with or without IVF. Criteria: no previous IVF. Now, people, there had been change in this. So previously, this age was 41, 42. So till the 42, NHS used to offer one cycle, but this age is decreased now. Now 40, 41 only one cycle is offered. So in this age is very important, because if your role player is 42 or 43 years and she came for the fertility options, you have to follow NHS. Now if your patient is like 40 years, she comes for fertility treatment, you can say we can offer one cycle. If your patient is 41 years or 42 years, then you have to say it more than 41, it will not be funded. Okay, no cycle will be funded. So this is a change in the guideline that is important for part 3 people. Basically the task comes from here. Now these are the few things, basics about the IVF I would explain you, and this is not from the NICE guideline. I just put some of the things. So just to explain the topic. So what is the IVF? In IVF, there is a pre-treatment evaluation is done, ovarian stimulation, monitoring of follicular development, usually by USG. Then trigger is given. Then egg is collected. Fertilization is done in the lab, and embryo is transferred. Luteal phase luteal support till the progesterone with the progesterone administration. So this is the basic thing that we say IVF. This is the steps of IVF. Now, like, what are the indications for IVF and ICSI treatment? So this part is not from the NICE, but these are the indications. Very important that for egg donation, surrogacy, embryo testing for monogenic disorders, structural chromosomal rearrangement, aneuploidy screening, fertility preservation for medical non-medical reason. So all these conditions are there where the IVF and ICSI is the treatment choice. Now, before IVF, what should not be done? This is important, because if you have to, your role player may ask you in the exam, endometrial scratch pre-treatment should not be done. Hysteroscopy should not be done. Usually, all IVF center they do hysteroscopy and endometrial scratch. No hysteroscopy, no endometrial scratch. Apart from this, treatment for endometrial receptivity testing should not be done. And because many of the fertility centers you will find they do endometrial receptor testing also. This will include gene expression analysis, for example, endometrial receptivity array, microbiological analysis they do for endometrial microbiome, metagenomic analysis, analysis of infection for chronic endometritis. It is done. But see, for you, for the sake of this exam and this guideline, it is no. Immunological agents, immunoglobulin, steroid should not be given as a part of fertility treatment. So all of this part is important for part 2 and part 3, because the role player asks you direct question. So I have heard about, hysteroscopy, I have heard about this, what about that, and you have to give answer no. Because of that, what is not offered according to this guideline, I have put in the slide. Now, these are few things, though we know from our UG days on also, but just a quick revision. We give GnRH agonist. GnRH agonist will uh, like block the action of GnRH. So LH and FSH will not be released. So initially, uh, however, initially there will be a release of FSH and LH. So this is called as a flare effect. So they work with the flare effect. The example is all this, uh, uh, like uh, visceralin, nephralin, GnRH antagonists. They block the receptor, block the release of FSH and LH. Flare effect will not be there. For example, cetromide or cetrolix and gonadotropins are there. Now these are the various kind of cycles. I will not go in the detail. This is from the 2018 talk that I have put. So there is a short cycle, there is a ultra short cycle, there is a long cycle, there is a GNH antagonist, fixed protocol, flexible protocol, single bolus. So many things. But I would not be explaining this. Now this is the long protocol. In long protocol, the usually the suppression is done like from previous cycle, like day 21 of the previous cycle. So there will be, from 21 days they give to do the suppression. When the endo down regulation is confirmed with the thin endometrium and estradiol levels, then ovarian stimulation is done with the FSH or HMG. Monitoring is done. After that, they put the trigger and they collect the embryo. They collect the eggs. The short cycle, short protocol, down regulation is not done. Okay. I'm not explaining these in detail. I have just put. Now, again for IVF, they have give this fertility guideline. They give link to the ashray only. So these are the few things I have put from ashray, though the ashray guideline is very big. So but few of the things that I think that is important for you, that I have put. So pituitary suppression and ovarian stimulation, gonadotropin dose should be 100 to less than 150. That will decrease the OHSS. Antagonist protocol is recommended. More than 300 international unit should not be given for the low predicted low responders. And like if the agonist protocol, then long agonist protocol is recommended. If basically the GnRH antagonist protocol, and that is a fixed GnRH antagonist protocol is recommended. So these are all recommendations. Apart from this, this should not be used. These are metformin, growth hormone, testosterone, DHEA, aspirin, sildenafil, and myoinositol. This is not recommended in IVF. Apart from this, when the patient is under the IVF cycle, there is a risk of multiple pregnancy and OHSS. So USG ovarian ultrasound monitoring should be done. Now, when the trigger to be given, so trigger to be given when the leading follicles are in between 16 to 22 mm of size. So 16 to 22 mm of size. This is from the ASHRAE guideline only. Now, these are the criteria for cycle cancellation. If more than 19 follicles, more than 11 mm is there. Now, for the trigger, the recombinant HCG or urinary HCG both are equally effective. If antagonist trigger is used, then it will be triptorelin, and the dose will be 0.1 to 0.5 milligram. Dual triggers are not recommended. Now, luteal phase support to be given for IVF and ICSI. So, any of the like routes, non-owner route for natural progesterone can be used. So, these are the ways the progesterone and is given in the doses only, but I am not reading that. So, progesterone support to be given until the day of the pregnancy test is positive. Okay. So previous guideline they used to say 8 weeks till pregnancy, but this ASHRAE they say progesterone support until the last, till the at least the day of pregnancy test. Dihydrogesterone can be recommended also. So these are the links of ASHRAE given in the NICE guideline, because previously they have given some IVF details in the NICE, but now they have removed it. Now, what to do to prevent OHSS? Trigger should be GnRH antagonist. Consideration for freeze-all strategies. That means the embryo transfer will be done in another cycle. And dopamine agonist can be used, such as bromocriptine. This is from ASHRAE. Okay, now this part I have put from the ASHRAE, and now it is again the NICE guideline. How this oocyte retrieval is done in conscious sedation. That is a safe and acceptable method of providing analgesia. If the patient has developed at least 3 follicles uh, before oocyte retrieval, should not be follicular flushing should not be offered. Assisted hatching is not recommended. Now, embryo transfer. Embryo transfer is USG guided. It should be if the ET is less than 5, it shouldn't embryo transfer is not done, because you can understand there should be a problem with the implantation. When the after embryo transfer, not more than 20 minutes of rest is required. Embryo quality, cleavage in the blastocyst stages are checked according to ARCS and UK NECAS criteria. Pre-implantation genetics should not be the part of it. Embryo transfer strategies. Apart from this, how many number of embryos are transferred? So this part is important. Usually, if the woman under 37 years, they offer 3 cycles. So one cycle, single embryo transfer. Second cycle, single transfer if it is top quality, otherwise two. And third cycle is two embryos. Okay. For women 7 to 39 years of age, first and second cycles single embryo transfer if it is top quality, otherwise double. And third cycle there will be double transfer. And 40-41 years there will be double transfer, embryo transfer only. So these embryo transfer strategies and the numbers according to the age you should be aware of. Embryo transfer based on the age of donor. Not more than 2 embryos are transferred. If the top quality is there, then only single embryo transfer is done. Uh, Otherwise, cryopreservation to be offered for remaining good quality embryos. Now, ICSI, when the ICSI to be done, if abnormal semen parameters, if previous failed IVFs. ICSI should not be done for non-male infertility, or as in it should not be done as in like IMSI should not be done as an adjunct to ICSI. That is the morphologically selected sperm injection, and PICSI is another method of selection of sperm. So that should, so IMSI and PICSI should not be used um, as reference or as an adjunct to the ICSI. So these are the indication for ICSI: abnormal semen parameters and previous IVF failure. Now, donor insemination. So these are the indication. So donor insemination to be considered if there is a obstructive or non-obstructive azoospermia or severe defects in semen quality. Donor insemination to be considered if there is a risk of transmitting a disease or infectious disorder. Before starting donor insemination, ovulation to be confirmed, tubal assessment if the history of tubal damage is there. So if your patient comes to you and she want, you are giving them donor insemination as an option, please make it sure the patient is ovulating. And if any high risk factor is there that suggests of tubal damage, then HSG should be done. These are the indication for oocyte donation: the ovarian failure, Turner syndrome, gonadal dysgenesis, bilateral oophorectomy, ovarian failure, chemo or radio, and certain cases of IVF failure, donor if there is a risk of transmitting a genetic disorder. Now, fertility preservation. So, fertility preservation to be offered as an option. Those who are going to medical treatment that would impair their fertility, that depends on patient diagnosis, treatment, outcome of the treatment, and the patient prognosis, that depends on the treatment condition. So, for NHS funded fertility preservation, criteria, like eligibility criteria used for conventional fertility treatment will not be there. So NHS funded fertility treatment criteria, if the patient is on treatment or if the patient is on conventional fertility, will be different. Cryopreservation to be offered to the male of a reproductive age person if they are going under treatment of a medical condition that will try to make them infertile. Then fertility preservation, this few things newly added. So for the the task part 3 task also come. So they should be offered egg preservation or embryo preservation. Apart from this, ovarian tissue cryopreservation if embryo preservation is not there. For example, if the patient is a young patient, like the pre-pubertal girl, where eggs cannot be taken out, that time ovarian tissue cryopreservation is done. For any other patient who is ovulating, egg or embryo preservation to be offered. After that, follow-up is done after every 5 years, and whether they want to continue NHS funded storage treatment or not. So, long-term effect of fertility treatment, though absolute risk is low, but there is a very small increased risk of borderline ovarian tumor cannot be excluded. And long-term effect, long-term adverse outcome in the children born out of IVF treatment, absolute risk of long-term effect are very low. So yeah, so this is all about the nice guideline fertility. Any one of you have any question with regards to that? So okay, now I'll be giving you some question for part 2, and there is a part 3 task. The those who one person who want to do part 3 task can write in the chat box, so one person can do. There's certain part 2 questions. So following statements are true with a recent change in WHO uh, parameter of a semen analysis. So what is the one statement that is true? No one want to answer? Okay, not an issue.
Sperm forward progressive mortality, no?
No, like normal one, which is true. One thing that is true. So true is morphology
Two
4%.
is second, yeah.
Yes. Okay. So answer A, normal morphology of 4% is optimal, and this is the new criteria from WHO. So a 28-year male trainer with in your clinic, these are the sperm result. So how do you describe the semen analysis report? So total, co- yes, yes.
Concentration is less, ma'am, and the
Number is
motility
less.
is less.
Motor.
Total sperm count is 16 normal, so that's fine. The sperm concentration is less, and the mortality is less, ma'am.
So
And
all
vitality is also less. Vitality for 54%. Yes.
so it is oligoestano.
Thinner to juice 4.
Yes. So 24-year-old lady attends with a history of failure to conceive 26 months, regular intercourse, no medical condition. Mid luteal progesterone is 36, 33 and 36. HSG bilateral tubes patent. Her partner is 36-year-old male, smoke 20 cigarette smokes, 12 units of alcohol, history of mumps. Semen analysis shows no sperm, FSH LH raised, serum testosterone low, no Y chromosome deletion. So, what is the management for this couple? What is the diagnosis first? So, see people,
So,
FSH LH, yes, yes.
is this, ma'am, uh, hypothalamic, like what I would like to tell?
No, no, no. It
Mm,
is hypothalamic. In hypothalamic, FSH LH will be low. Yes, very nice. Here, FSH LH is high,
okay.
testosterone is low. That
Yes.
means testicular destruction. Okay, testicular
Okay.
destruction.
Okay.
So,
Yeah.
so
A failure, ma'am. I'm sorry. Yeah.
this is testicular failure. So answer. So nothing can be given to the male. Answer will be donor insemination. Okay. So again, this is the semen. So what could be the parameters? What is the answer? So concentration is less, motility is less.
Ma'am, here it is again oligoacidosis.
Hmm.
Oligoacid.
Okay, so couple in the fertility clinic, 2 year trying to conceive. The female is 26-year-old with a BMI of 31, conceived 3 year ago. Healthy male, cesarean section was done. She has post-operative pyrexia. Antibiotics are given. Her 21 days progesterone is 55 and 41. Male partner is both clinical examination is fine. Semen analysis 25 million. Normal is 40, 10. Progressive motility 41. Rubella antibodies identified. So, what is the answer? So the female has so male parameters are fine. Female is ovulating. So what we need to check?
She, mm, tubes, ma'am.
Yes. Why tube? Because she has post-operative pyrexia and
Fever.
cessation.
Yeah.
So there could be adhesions. Okay. So lapendi. So if a couple of her to fertility clinic after 2 years, both partners are married before. Woman 31 years, never pregnant. Male 36 years, have one child before. Chemotherapy for lymphoma. Woman is menstruating, and progesterone estimations are 45 and 32. No problem in intercourse, and the semen shows uh, 1 million sperm. Volume is fine. Morphology is fine. Motility is 7 to 10. So, what to be done?
My screen question 5 is showing, ma'am. So
Yes,
could you
yes.
please? Question 5 is still showing, ma'am.
No, it is
Okay.
question 6.
I think net is something like that. Okay, sure.
Okay, and so anyone want to answer? So here female evaluation is fine only. Female is fine. Male has got motility is less, and also uh, like number is also less. So male has got problem. So
After three, it will be like, ma'am, severe, not no. So we will repeat after 3 months.
repeat,
And the semen analysis,
repeat semen analysis.
but it is severely.
Karyotype. But the patient has got chemotherapy as a
Okay. Oh.
so
Just
semen analysis.
question.
So here that means the suppression is there. Gonadotoxic treatment might have been
Mhm.
offered to the male partner, gonadotoxic treatment. So we have to find out whether testicular failure is there or not. So we have to do what? Hormone. For the
Testosterone, prolactin, FSH, LH.
yes, FSHLS testosterone. Because the patient has history
Okay.
of chemotherapy, severe oligospermia.
Mm.
Severe oligospermia.
Okay.
Because the history of chemotherapy is there, because of this is the answer, because might be the patient has got gonadotoxic treatment. So couple referred to fertility clinic 1 year after trying. 29-year-old. LMP was 3 weeks ago. She is menstruating every 5-6 months. Lot of weight. Diabetic 2 for years. Metformin twice daily. Smoker 5 to 10 cigarettes. Male partner is 38 years. 3 children from previous relationship. No problem during intercourse. Female has got clinical examination. Female has a BMI of 34. Semen analysis 15 million, 2.6 ml. Morphological sperms are 3. Progressive motility is 31. Rubella antibodies not identified. So what should be investigations? So here the male partner already have 3 children. So male fertility is out of order. Now coming to the female infertility. So the patient having very infrequent periods. She's diabetes and she's taking metformin. So possibly the patient is she's BMI is also high. So possibly the patient is having PCOS. So we have to we have to find out whether the patient is ovulating or not. So what investigation can be done? We have to do hormones. So hormone can be done when we will do hormone. Irregular periods, hormone has to be done.
Early follicle.
Early follicular phase when the patient have periods, if the periods are there in 5 to 6 months, so that whenever patient comes to you, you can take the sample. So
Okay, ma'am.
so profile hormone profile can be done on the same day.
Thank you, ma'am.
So patient is trying to conceive arranged marriage for 2 years. Woman is 20 years old, menstruating regularly. Day 21, progesterone is 65 and 39. The clinical examination, her hymen is intact. Semen analysis is fine. So what to be done? Hymen is intact.
Psychosexual assessment and counseling.
Yes. Hymen intact. So refer to the sexual therapy or advices because sex has not had happened yet. So the patient in the fertility clinic after 1 year trying to conceive, BMI is 29. Previously they conceived 15 months ago. Pregnancy was terminated because of Down syndrome. Now after that the patient has bleeding and more uh, period pains and the pelvic discomfort. Smear was fine and there is no obvious in frequency like sexual problems. Clinical examination is normal. Semen analysis 25 million. Normal formological forms are 10%. Progressive motility is 40 when double antibodies are detected. So what to do? What investigation to be done? So male is fine only. So coming to female. Coming to female.
Irregular bleeding after uh,
The high cervical irregular bleeding in between periods, more period pain, pelvic cervical smear is fine, so avoid cervical causes. Infection has been ruled out. Irregular bleeding after termination, though
we
it is
will
not.
do a scan.
A scan to exclude endometriosis.
Scan.
Before that, any pregnancy event,
UPT, UPT,
yes,
UPT, ma'am.
UPT. You have to rule out mole.
Oral pregnancy.
These are tricky questions, but these are from strategy only. Couple referred to fertility clinic after 1 year to conceive. 29-year female. She had episode of painful periods and painful sex, so Marina was inserted. Husband is 25-year-old, type 1 diabetes for 10 years, takes insulin, smoker, no problem with the sex, clinical examination is fine, BMI is 33, semen analysis is also fine. So what to be done? Why she is not getting pregnant?
Marina, no? She has
Marina.
a.
So you have to do what to find out?
Ma'am, first we have to remove it.
First you have to confirm, do pelvic ultrasound.
Okay. Oh, yeah.
Okay, now, so couple with a history of two miscarriages, day 21 progesterone is 25 on 2 occasion. So the patient is not ovulating and the semen is fine. So what you will offer? An ovulation. An ovulation, what you
Okay.
offer?
Progesterone, ma'am. Day
Ovulation
21.
induction, yaar.
Clomid.
Clomid. And according to new guideline, it
Yeah.
should be letrozole.
Letrozole.
But it is not given in the question. So answer remains clomid. Most common cause of testicular failure.
Idiopathic.
Idiopathic.
Yes, it is idiopathic. So single most marker of female reproductive outcome,
Female age.
Previous age. Age of the patient.
age, because the new guideline also says declines with the age. So most frequently test for ovarian reserve,
Initially, it was FSH. I don't know right now.
Intrafollicular count.
AMH only, AMH and AFC. This is
Okay,
the
ma'am.
new guideline,
Yes.
AMH and
Yes.
AFC. Best will be AMH only. Best test for fallopian function tube.
B. HSG.
C.
Spontaneous intrauterine
HSG.
pregnancy.
Actually, I was options. Spontaneous pregnancy.
Yes, a tricky question.
Yes.
Page
Yeah.
student, because of that, the take home message: read all 5 options before answering. Most appropriate treatment for hydrosalpinx prior to IVF.
Laparoscopic salpingectomy.
Yes. So it is laparoscopic self-ingectomy or tubal occlusion, and this is the update. If this surgery cannot be done, then aspiration of hydrosalpinx during the time of oocyte retrieval. This is update. So a 26-year-old, 46 years old woman with a IVF clinic, she wishes to get pregnant. Cycle is 28 days, 45 days, period lasting 1 to 2 days. FSH is 18, AMH is less than 1.1, pelvic sound ultrasound normal. This is the semen result. So what should be the treatment option?
Semen is also low. IV with donor eggs and donor sperm.
Donors with like 8 million is fine. Maybe required ICSI. So egg donation,
Okay, with ICSI, ma'am.
yes.
Uh,
So female has got low ovarian reserve that you can see from AMH. So female will require donated egg. Male oligospermia is there. So like ICSI would be the ICSI with the donated eggs would be the answer. So couple attend fertility clinic, irregular periods, f- and evidence of androgenism. AMH is 56. HSG fallopian tube main has azoospermia. She has been investigation testicular biopsy shows maturation arrest.
C, I think. Donor insemination.
Yes, but the patient also has got an ovulation. So ovulation induction and
induction and
SL.
intrauterine insemination.
ovulation induction for female and IUI.
I,
Okay. So couple refer to fertility clinic. Woman is 32 years old, no medical history, regular cycle of 28 years. Man is 34 years. She has orchidopexy for life, descended past test. Is two semen analysis are normal. These are the woman's result. So semen analysis is fine. Day progesterone is also fine. USG and HSG is also fine. Everything is fine only.
this is an unexplained infertility.
Yes, unexplained infertility, but have they tried for 2 years?
It is not given in ma'am question.
Yeah, it is not.
There.
So they can try themselves without any treatment
Mhm. Mm.
because
Yeah.
everything is fine only. So right now, because they have
Mhm.
mentioned the duration, if they mention duration less than 2 years, then they have to try naturally. More than two, IVF can be offered. A man have azoospermia, but he has two children from previous relationship. She denies any medical history. He's muscular, both testes are small and soft.
Steroid, anabolic steroid.
Muscular. Oh, yes, anabolic steroid should be the answer because he has got proven fertility
Mm.
and testis is getting smaller. So, anabolic steroid is the answer. The patient has azoospermia, normal secondary sexual characteristics, testis of normal size. Cystic fibrosis screen is also normal. Testicular biopsy shows germ cells to be present. So, no maturation is not there. So, a person has
Is
azoospermia.
this maturation arrest is there?
Yes, see, germ cells are there. There is spermatozoa is not there. That means the germ cells they are not producing spermatocyte and spermatozoa. So they are arrested. So men having azoospermia, FSH elevated, testosterone normal. She has gynecomastia. She is tall. So testis is soft and small. What is the diagnosis? Tall men.
Glenfell,
Glenfelter syndrome.
Glenfell syndrome.
Yes, tall men gynecomastia, Nefelter syndrome. Okay, 20-year-old woman with a history of failure to conceive for 14 months. Mid progesterone is 31 35. Semen is fine, tubes are patent. So, what to do?
Continue try for 10 months, ma'am. 24 months.
Yes, yes. So, she has to, before she's eligible for like IVF, or like IUI treatment, she should try it for complete 24 months, so 10 more months she should try. So here again the similar kind of answer. The 38-year-old woman failure to conceive 12 months. She has no medical history, regular period, and progesterone shows fine, tubal patency is fine. So answer is try for 12 months
12
more.
months.
No, no, no. Okay. Here the age of patient is 38.
Okay, so 36 more than 36.
So if the
Straightforward.
patient would require immediate treatment, she has already tried 2 years. So she's a woman for IVF because of the aging is a factor. So because of that treatment, whatever the questions we do, it is, we have to check each and every part. Here because of the age, answer changed. If the age becomes like less than 36, then answer will become try for more than 12 months. If the age is more than 36, then the answer becomes immediate treatment. So 21-year-old, and she has having 18 months of unprotected intercourse, and she has tried to conceive for 16 months, no success. Progesterones are fine, lab dye is fine. What to do?
I think uh, to
When,
continue try for another 6 months.
yes, to continue try for 6 months more. So year 34-year-old woman attends a failure to conceive for 24 months. She has tried. She has history of appendix, painful periods. Periods are regular. Lap and die bilateral patency. What to be done? So now tubes are fine. She has tried 2 years. She has got ovulation also. She has got one son lives with her. So what is the treatment?
Privately funded IVF.
Yes.
IVF.
Yes. So the patient has tried for 2 years. Answer will be IVF. But because she has got one child previously, so the treatment should be self-funded, and provision of IVF treatment depends on country and local integrated care board. There should be some additional criteria also. So these are the universal criteria for NHS funding. The couple should not have any child from current and previous relationship. BMI should be less than 30. They should not be smoking, and age related criteria. So 24-year-old woman attends clinic, failure to conceive for 18 months despite regular intercourse. She is having no medical history and regular menstrual period, healthy relationship, and 3-year-old child from previous relationship. What should be the most appropriate uh, diagnosis for unexplained infertility? What investigations?
Questions.
Uh, I think B.
Why you will do AMH? She's 24-year-old.
Yes.
Why you will do AMH? AMH for the ovarian reserve.
Mm.
So we have to see semen, we have to see ovulation, and we have to see tube. These are the three investigations. Now the answer becomes
D, ma'am.
D.
yes, very nice. So we have to check for egg. So in nice guideline, it is a mid-cycle progesterone. We have to see tubes, HSG, and semen. So if these three are the baseline investigations. Now, 30-year-old person Polish migrant have a massive PPH, needed aggressive transfusion. She referred by her GP because 4 months postnatally she has no menstruation. She's breastfeeding and recently introduced complementary feeds. Urine pregnancy test is negative. So why the patient is having amenorrhea?
uh, Sherman syndrome, I think. Pituitary.
So all of you agree with this Sheehan syndrome?
She has breastfed on demand. So
Yes.
I
mm,
So it could not be Sheehan syndrome. In Sheehan syndrome, the patient will have all,
lactation failure.
yes,
yes.
all hormones should go down. So it is not Sheehan. So it is what? Then the answer is easy.
Mm, this is
Physiological
physiological
Lactational amenorrhea.
Yes, it is physiological lactational amenorrhea. If you don't read the question carefully, all of maximum people will answer Sheehan syndrome. But in Sheehan syndrome, people post delivery, all hormone will go down, so she cannot breastfeed. Her thyroids will be deranged, and FSH, LH they will also go low. So the answer become physical amenorrhea. So because of that, whole question reading and checking every part of it is important. So 19-year-old uh, referred with a partner for primary infertility. She has an chronic transfusion therapy for sickle cell anemia, most recently diabetes, semen analysis, oligosospermia. The FSH LH abnormally low. What is the diagnosis? Why it is happening?
iron overload. No.
Yes, iron overload is the answer. 25-year-old student with a karyotype of XO 46 double X, mid luteal progesterone is 45. What is the risk she have?
Premature ovarian insufficiency.
POI.
What is the risk in the future?
Kind of access.
So 29-year-old woman, inability to conceive 12 months since stopping COC for 6 years. She's menstruating every 30 days. Mid cycle progesterone is 35. TVS shows polycystic ovaries. Semen analysis HSG is normal. What is the best match?
An ovulation.
Patient is
Ovulation is
ovulating.
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 Mm.
Progesterone is more than 30. So ovulation is there. Semen is fine. Tube is fine.
Unexplained.
Unexplained.
Unexplained infertility.
Yes. So 33-year-old woman trying successfully for 19 months. She menstruates every 24 hours. Progesterone on day 21 was 20. Which is the best? What is the
Is
problem?
an ovulation here.
This is ma'am mistimed blood sampling. We have to 24 days cycle.
Yes, because she's having 24 days cycle. So
Cycle.
24 minus 7. That means 17th day the test should be done. 7 days prior to period date. So answer is mismatched state. 42-year-old woman, infertility clinic, male partner is 38 years. He never fathered any child. Investigations were done. BMI 36, couple trying for 1 year. Female has a regular cycle. Male suffer from erectile dysfunction. They have penetrative sex with some difficulty. Male have history of a road traffic accident and spinal injury. Semen analysis low volume. All parameters are normal. Why it is happening? So what to be done?
Like erectile dysfunction.
I think
retrospect
It's
because
late
the age
full of
referred to IVF.
Yes, answer is IVF. Why IVF? Patient is 42 years. Okay.
Yes, 38.
So
It's 38.
patient female is 38 years age, male have erectile dysfunction and low volume semen. So they cannot ever get normal pregnancy. So IVF is the answer. Or maximum people will give retrograde ejaculation as an answer. But retrograde ejaculation, if it is there also, then also looking at age and erectile issues, natural pregnancy is not possible. 36-year old woman, healthy male, fertility clinic for fertility assessment. Never tried to have family before. Concerned about future fertility. Seeing various news in the social media. He is keen to have possible investigation options. He would be okay in future to start a family. So, what should be the best treatment we should offer? Investigation. What investigation she should go? He should go for. So, what is the first investigation we write in our clinics?
Semen.
Semen. 41-year-old male and 38-year female trying for 2 years. Male was offered testicular scan, left-sided varicocele. Male hormone profile is fine. Scrotal examination, normal size testis. No varicocele on scrotal examination. USG form normal testis. Fertility doctor is offering option. What is the option?
Uh,
IVF?
Ma'am, IVF need IVF treatment due to duration
Yes,
of.
because 2 years and 38 year of female. So there are two criteria because of that IVF. So 24-year-old male with 25-year female partner in the private clinic. They are trying for 6 months. Fertility assessment. The For reassurance, male partner has a low sperm count of 10 million. Concentration total count of 20. Morphology borderline. FSH is 9.1. Testosterone 12.3. LH is 6.4. Fertility doctor is discussing next step. What is the correct treatment? What should be done?
Lifestyle modification with the repeat semen.
Mm, yes, ideally yes. So the patient is having like impaired semen, and if the impaired semen is there, then after 3 months there should be repeat test. So medical student taking history for couples of the male is 28 year, female is 25 years. Pregnancy they are trying for 3 year. Male is very muscular, broad chested. Medical student forgot the history from the male patient. She's the what is the investigation result found to have azoospermia. Why which from the list is least likely to cause for this patient? So the patient is having azoospermia. So what should not be the cause for azoospermia?
Bilateral
Ma'am,
orchidopexy, maybe?
bilateral orchidopac.
This could this could be cause for azoospermia. There could be testicular damage.
It will be
Symmetry?
Yes. Cimetidine, because
okay.
cimetidine doesn't cause any azoospermia. Anabolic steroid can cause azoospermia. Alkylating agent is gonadotropics can cause azoospermia. Orchidopexy may be some damage may cause azoospermia. Cystic fibrosis can cause azoospermia. Cimetidine will not cause. So, like 47-year-old diabetic male with a female partner who is 34 years. He fathered two children with previous partner. Not had no difficulty in intercourse. GP arranged baseline investigation. The couple trying for a year. Patient has female has a regular cycle. Main semen analysis shows low volume. Other parameters are normal. Which of among is less likely cause for low semen volume?
You're calling is not answering.
Is this short
Please
duration
try
of
later.
abstinence, ma'am?
Uh,
Previously, he had two children.
no, now the volume is less.
So
The
it is
infection, why it's
diabetic,
going
ma'am.
low?
Poorly controlled diabetes
Advantage.
could.
Okay, diabetic. So see,
But he's not diabetic. Advantage.
It is
The
given
infection,
here, no?
bursitis, epididymitis, or varicocele.
Diabetic. Okay. And diabetes.
it is diabetic. So
Yes, yes.
poorly
Only
controlled
control.
diabetes is the answer.
Yes. Only control.
So 24-year-old woman attends the clinic with a failure to conceive for 26 months. Despite regular intercourse, she doesn't have any medical history. Her progesterone levels are 33 and 36. HSG is bilateral patent tube. Her partner is healthy, smoking. I have done this or not. 20 cigarettes. He drinks more than 12 units. He has a history of mumps. FSH LH are raised. Testosterone is low. He has a normal karyotype, no Y chromosome deletion. What is the options? This I think we have done this already. No.
I think donor elimination or
Hmm. FSH LH are raised. Karyotype is normal. Mumps. Testicular failure is there. Testicular failure is there. So answer could be either from donor insemination or it could be testicular sperm aspiration. Surgical method ICSI could be there. But they have not given the semen volume at all. They have not given the semen volume. They have not given azoospermia also. Basically, they should give some of these things. So answer could be either donor insemination or even like the testicular sperm aspiration could be also like surgical sperm aspiration could also be the answer. So answer is testicular sperm aspiration. So basically both are the options. Donor semen also and testicular semen aspiration. So if testicular surgical option is there, the question would have been more better if they would have given the semen parameters. But both are the answers. If I remove testicular sperm aspiration from the choices, answer will become donor insemination. So 25-year a couple diagnosed with anovulatory infertility and diagnosed with a PCOS, BMI is 24. What is the treatment option?
Ovarian drilling, ma'am.
What is the first line? You are going to
Ovulation induction with clomid.
Lifestyle modification will be the first line.
lifestyle, yes.
lifestyle should be the answer, but the BMI is 24.
Yes. Ovulation
So
induction with clomid.
So clomiphene will answer, ma'am. First line.
answer will be clomid with
Conditioning.
if I in if I write BMI 30 more than 30 in the question, answer will become lifestyle modification. But because
Mm.
the BMI is normal, answer becomes clomiphene or induction with a clomiphene or letrozole. So couple diagnosed with anovulatory infertility, patient is 32 with a PCOS. BMI is
Lifestyle mode.
here, it should be lifestyle modification. So now the couple, 2 years of infertility, 28 PCOS diagnosis, clomiphene 150 is daily dosing, no ovulation. They don't want medical treatment further. They wish to avoid intensive medical treatment.
Ovarian drilling.
Drilling is the answer. Because GNRH agonist multiple pregnancy and the uh, intensive monitoring is required. So as they don't want that, so answer will be LOD. So the patient with anovulated infertility, BMI 24, tried clomiphene citrate, ovulation but not yet pregnant. So what can be done? She's not responding, no response to PCOS, no response with the clomiphene. What next?
IVF.
Yes, because BMI 24 lifestyle modification will not come and she's not responding to medical treatment, so IVF. 30-year-old patient comes to you. She has absent periods while breastfeeding. She suffers from hair loss, vaginal dryness. BMI is 18. What is the explanation?
Lactational amenorrhea.
Lactational immunity.
Yes, lactation amenorrhea. So 13-year-old woman, irregular periods, menarche 1 year back, cycle ranges 21 to 45 days, no significant change in habit and weight fluctuation. Physical examination fine. What is the cause for her irregular periods?
Normal variation.
Normal variation, because stabilization of the axis will take 1.5 to 2 years. So the 22-year-old woman with a history of amenorrhea goes to pelvic ultrasound, multiple follicle, none of them is more than 12 mm, not arranged peripherally. Stroma is reduced. She is having hypogonadotropic hypogonadism. What is the explain? In ultrasound, what you will get? What is the answer? So is it PCOD?
Due to
Yes.
hypokinetic hypokinetic.
Yes.
Well,
Why it is not PCOS? Because in PCOS, follicle will arrange in periphery and the
Yes.
stroma will increase. The uterine stroma increase. Because of that, it is not PCOD, it is multicystic ovary because of the hypogonadism. So 32-year-old woman, irregular period, history of oligoanovulation, hirsutism. Testosterone is above normal. What are the investigations you will do?
ma'am, DHEA is
Yes.
917 hydroxyprozone.
Yes. 30-year-old woman with polycystic ovary, hirsutism, BMI 32, history of type 2 diabetes. Family history is not interested in OCP pills. What is the next step?
Metformin along with the lifestyle change.
Lifestyle change. Yes. So 28-year-old woman with irregular cycle, she is known case of her Cushing syndrome. Ovaries are polycystic. What is the mechanism by which Cushing syndrome is contributing ovulatory dysfunction? What?
Excess adrenal androgen.
Yes. Okay, so like 31-year-old woman with 1 year of subfertility, normal semen, normal cycles, she suffers from dysmenorrhea and menorrhagia. USG shows 4 centimeter endometriosis in left ovary and normal uterus. So, what is the tubal testing?
This diagnostic laparoscopy.
Yes, because the patient has got dysmenorrhea, so possibility endometriosis. So 36-year-old woman with 2 year secondary fertility, USG shows multiple fibroid and HSG contains regular tube. So what should be, semen analysis is fine. What is the appropriate investigations prior? They should, what should they should have?
Evaluation of the cavity, sonohysterography.
No sonohysteroscopy, hysteroscopy, because we want to see whether any submucosal fibroid is there or the cavity is distorted.
Mm.
Yes.
Staroscopy to exclude cavity compromise.
Yes. So 31-year old with the 31-year old with a tubal infertility for that.
Salpingectomy IVF.
Yes.
A.
Now I have got one task for part three. Who would like to?
Try, ma'am.
All of the other people, please put your mic. All of the other people mute. Okay, who want to do Sarika?
Yes, ma'am.
Okay, fine. So start. So there are two paper.
Okay.
Yes. Whenever you want, I will change.
Okay, ma'am. Previous one. Ma'am, the first one. Slide, please.
You can start. I'm setting the timer. Okay, start.
Hello, I'm Dr. Sarika, one of the doctor in the gynae clinic today. May I confirm your name and age, please?
Yeah, I'm Eva and I'm 18.
How can I address you?
Yeah, you can call me Eva only.
Okay, Eva. So, how can I help you, Eva, today?
Yeah, see that I'm having a very irregular, infrequent periods, and I'm really upset about that. Uh, GP started some pills, but I thought I stopped at
Mm-hmm.
myself because I'm
Mm-hmm.
gaining weight. That was a concern to me. So because of that, all these issues I have come.
Okay, Eva. So, what about your as you are a student, how's your school? Everything is good there? Are you
Yeah.
going?
Mm-hmm.
Okay, Eva. So, your main concerns is your periods, Eva. Apart from this, anything you want to
I'm having yeah, periods are main issue, and the facial
okay.
hair.
Okay, Eva. So, Eva, before going for the further discussion, I would may I ask some questions so that it will help us to make a better plan for you. Is that fine with you?
Yes.
Okay. So, Eva, have you ever as you given in your notes that you have bills by the GP? Any other treatment you have taken
No, no.
for this or any other consultation? Okay. When was your last menstrual period, Eva?
2 week back.
Okay. And otherwise, when you have started OC pills, before that, well, your periods were also irregular. From very starting, it's irregular.
Yeah, yeah, they are irregular only.
Do you have any medical condition?
No.
And any family history of concern,
No.
PCOD or
No. No.
okay. What about are you allergic to any medication, Eva?
No. No. No allergies.
Uh, okay. Don't mind me asking. This is a routine question we ask every young girl who comes. Do you smoke, Eva?
No. No.
Any alcohol?
Occasionally at the parties.
Okay. Any drugs from fun?
No. No.
Okay. What about support at home?
Yeah, my parents are supportive.
Okay. And okay, Eva. So I can see, Eva, right now, your main concerns is your periods, and you have started like taking pills. But that like it's because of adding to your weight, you have stopped. And we are here to discuss about your management plan. Is that right, Eva?
Yes. Yes.
Eva, I would like to examine you in the present just to see your observation and reconfirm your height weight ratio. Is that fine with you?
Mm-hmm.
Okay, Eva. So, you have went through that some test, Eva. So, do you have any idea has come?
No.
And
No.
G, okay. So, coming to your reports, Eva, I have confirmed your name and NH, and we here done like your scan of the your womb, and the good thing is the findings are normal, and we have done some test, hormone test also. So here there are two hormones uh, produced by egg basket, and one of the hormone is towards in the higher range, and rest hormones are normal. So am I clear?
Mm-hmm.
Okay. So as we can see that your height weight ratio is slightly towards the higher side, and your one of the hormone, that is LH, this is hormone is responsible for, I would show you with this diagram, is the ovulation. Ovulation is a when in the menstrual cycle we timely our egg releases, then periods comes in a normal pattern. Am I clear, Eva?
Mm-hmm.
And when these hormones have a slight uh, ratio is deranged, the ovulation is not coming, is not happening on the proper date, and that's why we are not getting the periods on time. So this condition is called as polycystic ovarian disease. But Eva, first, this is a diagnosis of exclusion. So first, before confirming that, like this is a case in your diagnosis in your case, we have to do some other test to confirm that it is because of that only. Am I clear?
So, what test is required?
Okay. So here actually we have to test in the PCOS. This is symptoms are polycystic kidney ovaries, and also some clinical or biochemical evidences of hyperandrogenism. So we have to do some tests testosterone, free testosterone testing, and also we have to rule out any other source of androgens, any other source of excluding some uh, other diseases, like any androgen secreting tumor, and or to rule out you are having this condition only, because in a PCOS the free testosterone level and the uh, also there is index we calculate by the sex hormone binding capacity. We have to check those tests, and when these tests will come, we will be able to like make the diagnosis. Am I clear, Eva?
Mm-hmm.
Okay, so as you are having not your like it is a diagnosis of clinical presentation, you are not having your periods regular, and your height weight ratio is also towards the higher side. So we will make a, like a start with the this treatment comes with lifestyle modification first. So we will advise you to start doing some changes in your diet, and also try to lose some weight, and do follow like a exercise program. So if you will be able to lose at least some pounds of weight, that will also help to improve your condition.
Mm-hmm.
Am I clear? And
Yes.
as you are having this excess facial hair, so this is also an indirect evidence that testosterone is a male hormone, so it has to be in a less like a less level in the female. It has to be level has to be in a less. So it is like showing that your body is producing more male hormones, so we have to detect that. And am I clear?
Mm-hmm.
So Eva, first we will see my senior consultant, gynecologist, and also will involve the hormone doctor to see your condition closely about your hormone test, and to guide more about this. As your scan is right now normal, we are not finding that typical picture we find in a polycystic ovarian syndrome. So we have to make a senior input to confirm the diagnosis, and exclude the other causes of these excess facial hairs. Am I clear?
Mm-hmm.
So meanwhile, we will start with the lifestyle modification, and then we'll follow with you the test. I think time up, ma'am. Yeah.
Mm.
Okay. Thank you, ma'am.
So how did it?
Actually, I'm not so. Actually, the scan is normal, ma'am. So I was not sure which, and LH is raised. So I'm not
It
sure whether I did. Whether I
is a
did.
these are periphery arranged follicles, and LH FSH LH ratio is disturbed. Is it not PCOS? I think
Yes.
it's PCOS.
PCOD only. See, the
Yes.
follicles are arranged peripherally, and increased trauma is there.
Okay,
Okay.
She
ma'am.
has
Apart,
oligomenon.
so this is polycystic appearance of the ovary. Apart from this, the one very much classical thing what you see is LH is it is
Double.
double than the FSH. Patient is having irregular periods. So what else you need? So it is PCOD only.
Okay, ma'am.
Okay. So, uh, like easy station, not very difficult. So, information gathering is fine. Very important part, you have to check the sexual history. She's a young girl, 18 years. So, sexual history, apart from the what history you have taken, sexual history is must. Because if she's sexually active, you have to do UPT. That would be patient safety. Number one. Number two, the patient has taken CUC and she left it. So, a bit detailed history there. What whether she can name the COC and how long she has taken, whether there was any improvement there or not, whether she what kind of treatment she has got. So treatment history also you have to mention. So like history taking only this much only 2 points. When you are explaining me, you are taking very long time to explain PCOS. You know, so you have to take less time. then you spend at least 1.5 minutes in explaining testosterone, male hormone, free androgen, and index or whatever. See, so much investigations are not required. Just say, the first of all, for PCOS diagnosis, clinical hyperandrogenism is there only. She is having facial hairs. Okay. Apart from this, you have to also take history of acne, oily, greasy skin, and skin thickening, like acanthosis nigricans. These are the symptoms of PCOD that you should have asked in the history. So apart from this, you wasted so much of time in androgen testing. So every time androgen testing will not be done because the patient is symptomatic, number one. Number two, if you want to do androgen test, you have to just say simply in a one line, we need to check for, your levels of the androgen hormone also, because that could be raised as well. Finish. So then you said it is a diagnosis by exclusion and all. So that is not required because you have got investigated case. It is investigation you have been if I remove this second slide of investigation, then you have to say that possibly this, and we need to investigate further to rule out other causes. But now you cannot say this because they have given you fully investigated case. So now, other causes you have to rule out, that part you should not mention. So apart from this, in the applied knowledge, a better explanation of PCOS is required, and weight modification, yes, that you have said, but from where she can take help, that you have to tell her. Then her main concern is period. So you have to give her COC again. You could have given her cyprotrone acetate, like that drospirenone pill, or that cyprotrone pill can be given. So drospirenone containing pill or dronis will be fine here, because that will decrease her hormone, that will stabilize the hormone, that will reduce the weight also. So that you could have said, but that period regularity part, you didn't reach up to that. So see, the concern of patient was not answered. Then PCOS patient, they, what are the long term health issues could be there, and you have to give them advice about the regular health checks also. Then this will be the complete answer. Is it clear, Sarika?
Yes, ma'am. Yes, ma'am. Clear. Thank you, ma'am.
Apart from this, you are saying egg basket. Please like remove this basket from your answer, because you are dealing with the UK role players. They know what is ovary, so you have to utter the word ovary. Or if you want to describe, you can say that the ovary, the organ, they produce egg. Finish. But don't say this basket, because one time one of the student has got a very hard time from the basket, and the role player took away 3 minutes, in because in the basket word. So please do avoid that.
Mhm. Sure, ma'am.
Okay.
Ma'am, for BMI also, we have to say BMI or height weight
Yeah,
ratio.
yeah, yeah. BMI they understand. BMI they understand.
They understand.
Because see, you are meeting with a UK patient. They English is their
Mm-hmm.
first language, so they know. Okay.
Okay, ma'am.
Okay.
Sure, ma'am.
Very
Thank
nice.
you.
So let me give you the answer. So the patient is 18 years old. She has irregular infrequent periods. She was given COC, but she stopped. She facial hairs are there. BMI is high. Investigations, you can see the LH is higher than FSH. So it is LH. This ratio is characteristic of PCOD. Apart from this, USG done, and USG, see, previously their peripherally arranged follicles and increased trauma. Though the definition of USG with the PCOS have changed now. Now they count the number of follicles in whole ovary. Okay, so it is fine, but if you correlate everything, then it is going towards PCOS only. And so, see, PCOD is like every second day in your OPDs, you are seeing PCOD. So it is easy topic, and the everything in 10 minutes has to be completed. Otherwise, your applied knowledge, if it is not completed, your marks will go. So how to answer? Hello, Eva. I'm the doctor from the gynecology clinic today. I can see we are meeting today because you have done your periods are irregular, and also you have done the scan and the blood test. And today, my job would be to discuss that. Any other concern you do have? Eva, can you give me the details about your periods? So you have irregular. So how often you have your periods? How many days you bleed? And you when you have period last, and how long you're having irregular periods, like you're 18 years since the starting you're having this periods, or like later on you developed irregular periods. Apart from this, you have taken some COC treatment, as I could see. So can you give me the details of that? Do you know that what type of tablet you were taking? Were you compliant with the treatment? How many months you have taken that treatment, and with the treatment do you think your symptoms were controlled, and why you have stopped them? So do you think the weight gain was there only with the tablets, or prior to that as well? So take that history. Apart from this, I can also see that you're having facial hairs. How long you're having that? Are they increasing rapidly or slowly? Rapidly, we are asking to rule out tumor. So we have to ask in the history, okay? Do you think they are increasing on a frequently or slowly progress? Any oily skin, any acne is there? And any dark skin around the neck? And does it impact your quality of life? So are you doing anything for the facial hairs, anything? uh, you're a young girl, but any pregnancy and the plan for it? Recently, are you sexually active? Now, any regular medication, any medication for thyroid, anything, any allergy, any operation? Your mom, sister having similar periods problem? Any issues with the blood pressure, or sugars? Some social well-being, questions. Any smoking, any alcohol, any drug for fun? Are you a student? How is studies going on? Is it is really impacting your mental health? You're feeling low, anxious, anything? I could see your BMI is 31, isn't it? Any further information you would like to add? Now, Eva, though your BMI has already been given to you, I will just like to check whether you're having acne or your facial hair. Will that be okay for you? Actually, have you got any idea about the investigations? Your scan has been done as per your choice. So that shows your womb is fine. There's some issues with the ovary, and we have done a couple of blood tests for you that checks for your hormone. So your hormones are kind of deranged. So kind of FSH is low, and LH is high. So other hormones are fine. So what does it mean? So you're if I look at if you're we look at your symptoms, your blood scan, your blood test, and your scan and result, all of this gives us a picture. You're having a condition that is called polycystic ovarian syndrome. It is a common condition that affects, and the woman's ovary will not work the way it should. It can happen when in 5 women. So actually, like in the polycystic ovarian syndrome, in the ovaries there are harmless, underdeveloped fluid filled sacs are there, and that means the ovary is not working and the ovulation is not happening. Why it happens? Because there have been imbalance in the hormone. So when excessive amount of hormone is there, that is like insulin, and the body doesn't respond to it, that is insulin resistance. Because to overcome that, the body produces excess amount of insulin. uh, because of that, your periods are regular, you have weight gain, issues with the fertility is there. That may also linked with a high level of testosterone or androgen hormones. So that would be responsible for causing not releasing eggs, your increased hair, and the acne. So this is basically a hormonal issue. I'm clear about that. So it is nothing to worry. We do have a plan for you. So there is a stepwise management plan. So lifestyle modification. See, healthy balanced diet, taking whole wheat grains and the cereals, fruits, vegetables, and cutting on the junks, sugars, and the salts. And I will refer you to the dietitian, so proper customized diet plan for you. So basically, we aim to have an BMI in between 19 to 24, and yours is 31. If you are able to, cut down few of your pounds, then you will see the visible changes, in your periods, improves your acne, and improve your general health, and also it decreases the long-term risk that is associated with a polycystic ovarian syndrome, sort of a blood pressure, sugars. Does it make sense for you? So apart from this, there are certain groups in the exercise programs. I can give you a link to that as well. So the going for lifestyle modification would be the first job. Now, most likely the things will go fine with that, but if your periods are really causing a trouble to you, we can offer you some other kind of hormones that will take care. With that, you will not increase weight, your periods becomes regular, and also that will take care of your cause reduction in the normalizes your hormones. So you will see a reduction in the hair growth also. We do have a drosperinone containing pills, so if you're okay with that, we can offer you that as well. So apart from this, for the hairs, some of these hormones will help. Some cosmetic treatments are also there in the local treatment. So try it with all this and see how it goes. And as I said, that this condition associated with the long-term effects of high blood pressure, sugar, if the periods are not coming longer time, possibility of womb, is cancer could also be there. Though it is, so we want you to have a regular health checks at your GP also. So any other way I can help you with any sort of concern that I haven't answered. So let me document this and give you reading material. We do have a support group Verity. So let's start with the lifestyle modification first, and also let me give you arrange you could like offer the treatment to regularize your period. You can consider taking that, the pendrosperinone containing pill. That is so. Will that be okay for you? Any other way I can help you with? Thank you for letting me explain. Sarika, any question?
No, ma'am. Thank you, ma'am. Clear.
So, though it is a very easy station, but see, completing all parts will be important. If you have not completed your applied knowledge, then also your answer becomes borderline. Okay. So, modification of like proper arrangement of your answer and taking history within 3.5 minutes and putting everything in the applied knowledge that is required. PCOD is very very important topic. Every exam, some varying scenario of PCOD always comes. Okay, so this is like ASHRAE guideline, PCOD. So this is what they are saying. All this thing that I have is put the screenshot. So this is the first line treat pharmacological education lifestyle and pharmacological therapy will be COC first. So low estrogen COC. Apart from this, like ethylene estradiol cyproton acetate can also be given. Apart from this, so these are the hirsutism would require COC and additional cosmetic treatment. Apart from this, this is the second line therapy that is written in the guideline. You guys can read it from yourself. I just put it from the ASHRAE guideline because that will be necessary, because now the PCOS guideline for the RCOG is not there. And this is the anti-obesity pharmacological management, that is again from the ASHRAE. So that also you should be aware of, because I have heard one role player was asking this. So these are the anti-obesity medication: liraglutide, semaglutide, GLP-1 injections are there. You already know these so much of like they are in the fashions now, and the orly strat are also there. So these are the few things that you should be aware of, because the role player is asking in the exam, and the part two people may get question also. That's it for today. Anyone have any question can ask me.
Ma'am, in this question, after the sexual history, do we need to ask about her fertility wishes?
You can say what are the plans for the future. You can say.
Okay, and can we prescribe us her eflornithine for excessive facial hairs?
If that is her, you can consider giving local application of eflornithine. But if that is her main concern, apart from this, if drospirenol containing pill, these are anti-mineral corticoid effect is there. So this mechanism of action that decreases androgen, so that will take care. If she is not responding to that also, then further treatment for hirsutism would be required.
Okay, ma'am, if she has fertility wishes, then we will prescribe her lifestyle modifications along with metformin and ovulation induction. Then we will not give her this drospirenone. Is it correct?
Yes, that time you, but you ovulation induction will not be done at 31 BMI. The patient has, because she's a young girl, you have to start with the
Okay,
lifestyle modification only.
okay, okay,
Yes. Any other question? Bye, people.
Ma'am.
Thanks for
Thank you,
joining.
ma'am.
Thank you, doctor.
Bye.